Hello, everybody. This week we want to discuss statin drugs and get an updated look at their efficacy. And we want to do this because statin drugs are the highest selling drugs of all time, and they claim to prevent heart disease and stroke and lower all-cause mortality in people with high cholesterol. So we just want to dive in and see, is that true, and use new studies to look at that and determine their efficacy. And efficacy, the definition of efficacy is whether something achieves its intended goal. So if something has high efficacy or is efficacious, then we would say this thing does what it says it does. If it has low efficacy or is non-efficacious, then it basically is misinformation, disinformation, false advertising, however you want to term it. So statin drugs have been available for about 30 years. Like I said, the statin drug class is the highest selling class of drugs of all time. And again, what they say is that they help reduce heart disease and stroke. So let's dig into that today. So I want to lead with, this is for informational purposes only. If I'm your doctor, let's talk if you want to discuss this further, and if you're on statin drugs and want to make changes to that. I still can't do that for you. That's between you and your prescriber, but we can speak with your prescriber together. If you are not a patient of mine, then do not make any changes to your medications or your health without speaking to your provider that you're working with. So this is for information only. So you've heard the propaganda for 20 plus years at least, actually back to the 50s, and Ansel Keys' research on cholesterol and the heart cholesterol myth. Basically, you've seen commercials where there's a clogged drain, and that's the metaphor for your vessels being plugged by cholesterol. Or you've seen the propaganda about bacon or eggs or fat killing you because it causes clogged arteries. Well, that's not true. And when you go to your doctor's office and they run a lipid panel on you, they're looking at your total cholesterol, your LDL, your HDL, your triglycerides. And essentially what they're looking for is high cholesterol, because high cholesterol or high LDL can be found in just about anybody. And it's an easy target to prescribe a medication and make you a lifelong patient. If you pay attention to quote unquote normal ranges on labs, if you had labs from 1990, from the 1990s, and then in the early 2000s, and then today, you will see that the quote normal range for total cholesterol has decreased with each decade. And that's not because, we need our cholesterol to be lower. It's because if the normal range is lower, then more people fall into the high range, making the market larger. And so again, the propaganda is that your risk of death from cardiovascular disease, from stroke, goes up with higher total cholesterol and higher LDL, as my little graph here shows you. Is that true? No. If you look at research that is not funded by pharmaceutical companies, but is actually seeking truth, we see a different pattern than this linear pattern here. And we've covered this study in great detail in a previous video, so I'll send you to my YouTube channel to check that one out. But in that video, we look at this study, and this study was published in 2019, and it looked at 13 million adults, sex and age matched, and it was looking at total cholesterol levels and all-cause mortality risk. All-cause mortality is risk of death from all causes, so heart disease, stroke, but also anything else. And what they found was that the curve does not look like this. The curve is actually U-shaped and looks like this. And so the true cholesterol death or cholesterol heart disease, cholesterol risk curve is U-shaped from age 35 up. So you can see in the upper right-hand corner there, from age 35 to 44, what the risk levels are, then from 45 to 54, 55 to 64, and on up. And as you can see, when it's a U-shaped curve, there is a low point that's too low, and the lower you go, the higher your risk of death from all causes. You can also see there's a point where it's too high, and if you go higher than a certain level, your risk of death from all causes goes up. And then with a U shape, where the bottom of the U would be, that would be the ideal spot or the optimal spot. So you can see in the upper right hand corner for the age group that is 35 to 54, optimal optimal total cholesterol level based on risk is at 220. Okay, but if you go tonight after this call and you pull out your recent lab results from your recent yearly physical, if it was from LabCorp or Quest Diagnostics, you're going to notice that the normal range for total cholesterol is less than 200. And it's going to be that way regardless of your age, which is another problem, right? But for someone 35 to 44, 200 is not ideal. 220 is. Okay, they want you less than 200. So they drive you down to 180. They drive you down to 160. You see it really start to take off from a risk perspective. Say you're 45 to 54. Well, now look at your curves. Okay, 220 is ideal for that age based on this study covering 13 million people. But if they put you down to 180 and 170, you really start to take off. Okay, so same for 55 to 64. So it's the propaganda and the reality don't match up. So this study was from 2019. What about more recent studies? Have things changed? Has more data made this study look wrong? Well, here's a study from 2021 in the British Medical Journal, and they're talking about new cholesterol targets. So we'll just read the abstract here. It says, drug treatment to reduce cholesterol to new target levels is now recommended in 4 moderate to high risk patient populations. So basically they're saying statin drugs are recommended in these 4 groups. Patients who've already had a cardiovascular event, so a heart attack or a stroke, adult diabetic patients, people with LDL greater than 190, and people with an estimated 10-year cardiovascular risk greater than 7.5%. So basically, those are the benchmarks set out for prescribing physicians to say, hey, if you have an adult with diabetes, put them on a statin. Okay, that is the benchmark they're looking at. Well, what if their total cholesterol is 200 or 205? Doesn't matter, they have diabetes, put them on a statin. Well, what about lowering cholesterol too low? A postmenopausal female, once you lower cholesterol below 180, you're drastically increasing the risk of type 2 diabetes and breast cancer. So we shouldn't just reflexively put people on statins because they meet a certain benchmark. And that's what this study said. Highlighted, you can see, quote, achieving these cholesterol target levels did not confer additional benefit in the systematic review of 35 different papers or studies that we looked at. Recommending cholesterol lowering treatment based on estimated cardiovascular risk fails to identify many high-risk patients and may lead to unnecessary treatment of low-risk individuals. So this paper from British Medical Journal says we shouldn't just reflexively be slinging statins. We need to, essentially, what's implicit in that is we need to be looking at each individual case individually and specifically. We have an even newer paper, hot off the presses here, from the Journal of the American Medical Association Internal Medicine, and it's titled Evaluating the Association Between LDL, so low density lipoprotein cholesterol reduction, and relative and absolute effects of statin treatment. So this paper looked at the association between your LDL levels and risk reduction by taking statins. Okay, and they looked at relative risk and absolute risk. So reduction of all-cause mortality or death from all causes, reduction of heart disease or heart attack, and reduction of stroke. So let's dig into this a little bit more. There are lies, damn lies, in statistics. That's a quote from Mark Twain that I love, because essentially, you can use statistics to make something say anything you want it to say. And so this information is from this study right here. Okay, so this study looked at 21 different studies, did a meta-analysis of 21 different studies, which a meta-analysis is you group a bunch of studies together. So you have all the data from all 21 studies in this case. And with more data, you can have more statistical power to make statements one way or the other. So they're using 21 different studies, combining their data to make these statements or show us these stats. So the first thing to understand is relative risk reduction and absolute risk reduction. Relative risk. So say we have two people and we give them both a medication. One dies, one doesn't. Okay, so the relative risk reduction of, sorry, let me back up. Say you're studying a specific outcome. So you're studying heart disease. You're studying heart attacks, okay, and death from heart attacks. And you have two people who have a high risk of dying from a heart attack. You put them both on the statin drug, for example, and only one of them dies, the other one doesn't. Okay, the absolute risk reduction was 1 out of 2, right? One person was saved, one person died. So 1 out of 2. The relative risk reduction was 50%, right? Because half the people lived. So I hope you can see the statistical game that can be played here is if you use relative risk, you can really, make people believe something works better than it does. And so that's what these authors said has been going on with statins. You can see there the relative risk reduction of statins for all-cause mortality, so death from all causes, is 9%. The relative risk reduction of statins of heart attack is 29%, and of stroke is 14%, respectively. So, if you're someone that's got heart disease in your family, so to speak, and you're scared of having a heart attack because your dad did and your grandpa did and whoever did, well then taking a medication that would provide you a 30% reduction of risk there sounds like a pretty decent idea. You could decrease your risk of a heart attack by 1/3 if that's true. But they don't come out and say, well, the stats we're telling you are the relative stats. Okay, because now if you take those same statistics and you look at the absolute reduction of risk, absolute statin reduction of all-cause mortality risk is only 0.8%, so less than 1%. The statin absolute risk reduction for heart attack is only 1.3%, not 29%, okay, 1.3%. And the statin reduction of stroke risk is only 0.4%. So now it starts to look a lot less efficacious, right? We went from relative risk to absolute risk, and the absolute numbers are not very good. So the image here is basically mind blown, right? This guy's head is just exploding because he's like, but all the marketing I've ever heard says these things work and decrease death and save my life. And now you're telling me they work less than 1%. What else did the authors of the study have to say? They said, quote, reporting the reduction of cardiovascular outcomes as relative risk reduction without reporting the corresponding absolute risk reduction has the potential to inflate the clinical importance of an intervention and may exaggerate trivial associations. When considering the absolute risk reduction of statins, the benefits are quite modest, okay, 1%. I think modest is not, 1% isn't even modest, it's pretty much pitiful. Okay, so they're being very nice by using the word modest there. And quote, most trial participants who took statins derived no clinical benefit. Okay, so if you're taking a medication, there's risk and reward supposedly, right? Well, if the participants received 0 clinical benefit, then that means those participants are exposed to 100% risk. Okay, if you are using an intervention, whether it's a statin drug or fish oil or whatever it is, there's risks and benefits and alternatives to everything. So you have to look at the risk and benefit ratio. Well, if there's 0 benefit, then it's 100% risk no matter what it is. So it doesn't make sense to take on 100% risk, right? Because now you're guaranteed something bad. Even if even if it's not an explicit side effect, but it's just, here's a added toxic load for your liver to have to detoxify. It has to focus on something else for no reason because you're swallowing it, and you're pulling basically its energies away from doing something that could benefit you. So we want to know absolute risk reduction whenever possible, because that's what's really happening. Now, another thing you want to know about a medication is the number needed to treat. And if we use the author's calculations from all 21 pooled trials in the study, they came up with the number needed to treat means basically to prevent one heart attack, 77 people would have to take a statin for 4.5 years, or 4.4 years. Okay, that's to prevent one heart attack in one person, not in 77 people. Okay, so 77 people have to take a statin for 4.4 years to prevent one heart attack. Well, what about the one heart attack that's prevented? What about all the side effects and all the damage that people had to sustain in order to prevent that one heart attack? In the previous videos on statins, I talk about statin side effects, and there's many of them, from joint pain to muscle pain to transient global amnesia. So basically you black out and forget where you are and where you're going and how you got here. We've talked previously that statins cause deficiencies in CoQ10. They deplete your selenium and glutathione and vitamin K levels. And vitamin K helps prevent atherosclerosis and clotting, which could cause heart disease. So the statin is potentially, in the people where it's decreasing your vitamin K levels, is making your risk greater for atherosclerosis and clotting, plaquing. So number needed to treat has been covered in other videos as well, not by me, but other, like documentaries on statin drugs. So there's more out there that you need to know before just hopping on these. And that's why we need informed consent. And informed consent is whenever a treatment is offered to a patient, they should be explained thoroughly the benefits of the treatment, the risks of the treatment, the alternatives to the treatment. And so if you're put on a medication and they just say, yeah, this is great, you're going to see rainbows and unicorns, and you don't hear the fine print, you should be worried. Stephanie Seneff is a PhD at MIT. She's a brilliant lady, and she wrote a paper called How Statins Really Work, explains why they don't really work. And in her concluding remarks, she said, every individual gets at most only one chance to grow old. When you experience your body falling apart, it is easy to imagine that this is just due to the fact that you are advancing in age. I think the best way to characterize statin therapy is that it makes you grow older faster. Mobility is a great miracle that cholesterol has enabled in all animals. By suppressing cholesterol synthesis, statin drugs can destroy that mobility. No study has shown that statins improve all-cause mortality statistics, but there can be no doubt that statins will make your remaining days on Earth a lot less pleasant than they would be otherwise. So if you're on statin drugs, or you have a family member that's on statin drugs, or you're being told you need to get on them, again, pull these papers up and show them to your prescriber and have the conversation. Ask them about, about why you need it. Ask them what level they want your cholesterol to be, because oftentimes they're reflexively prescribing because that's standard of care, and they haven't read these papers. They don't know what the side effects are in terms of nutritional deficiencies, etc. And so if you ask them that question and you just see a deer in headlights, you might want to run and find a different prescriber, unless that prescriber's going to read these papers, educate themselves, and then have the conversation with you. At minimum, your quality of life depends on it, and at maximum, your life depends on it. So, if you take a statin, your quality of life could suffer for the various side effects we talked about. If you take a statin and it's causing depletions in various nutrients, and you have a transient global amnesia attack and you're driving, it's possible you could die from a car crash. or various other reasons. So have these conversations with your prescriber, ask them what the end goal is, okay? And ask them, well, what raises my cholesterol? You know, because cholesterol is really just an inflammatory marker. If your cholesterol is high, you're inflamed. And so the real issue is you need to find the inflammation. Where is it? Why is it there? Address that cause, answer those questions. And if you eliminate the inflammation and retest your cholesterol, oftentimes your cholesterol's good and where it needs to be for you. So rather than stamp out the cholesterol, address the cause. Okay, you don't want to put duct tape over a check engine light by taking a statin to cover up your cholesterol. You want to say, well, why is the check engine light on? Go address the issue in the engine, and then you don't need the duct tape.
What drug do they give, like, on a serious note? What actually works? Like, these don't work, you know?
Well, you know, it's about, are they doing what they're intended to do, right? So for a medication to be called a medication, essentially it has to block about 90% of a physiologic pathway. And that's why medications have such high side effect profiles, because if you're cutting a pathway off 90%, say, well, then you're addressing or you're blocking anything downstream from that pathway. So I've talked about it in previous videos on statins, but to make cholesterol requires 32 steps in your body. And the statin drugs, the HMG-CoA reductase inhibitors, they block that pathway at step 3. So anything step 4, 5, 6, 7, all the way up to 32 gets drastically reduced. Well, below step 4, you're making your sex hormones, your testosterone, your estrogens, you're making your vitamin D and your CoQ10, you're rebuilding new cells, you're doing all kinds of things. So if you're taking a statin drug, you're depleting those pathways. So now your sex hormones could take a hit, or your vitamin D levels could take a hit, or your energy takes a hit because the drugs cause a depletion in CoQ10, which is needed for energy production. Maybe you have libido issues, or maybe you have the muscle pains associated with it, or you have muscle breakdown and it clogs your kidneys and you have issues with that. So the question is, why are we putting the person on the medication? What is our goal and outcome? And if we reach that, are we taking them off the medication? And then all this, even the statin commercials, they know the gold standard of high cholesterol is to first try intensive lifestyle change, so nutrition change and physical activity change. And you'll even hear on the commercials, when lifestyle and diet are not enough, take the statin. But in the actual medical office, that conversation about lifestyle and what you could do nutritionally and change your physical activity almost never happens. So if it did, a lot of people wouldn't have to go on the statins, and then essentially to that model they lose money. So health doesn't lead to money for pharmaceutical companies. People on medications for the rest of their life does. So it's not that there's not a time and place for medications, but it's that our model is built on not even asking what's the time and place. It's, hey, you've got this, which means the algorithm says give you this. Supplements, on the other hand, natural products like herbs and vitamins and things like that, if they have inhibitory properties on the physiologic pathway, they tend to be only about 65% of an inhibition. So the side effect profile of, say, an herb is much lower than a medication because it's not blocking so much physiology. And also oftentimes the vitamins and herbs or whatever you're using are like Swiss Army knives. They have lots of jobs and effects in the body. So there's a lot of collateral benefit potentially from say taking one herb versus taking one drug, because the herb affects many pathways, whereas the drug has been built to only affect this one. So that's a good question.
Good. I was looking at I was just curious what my LDL was showing. Because we've talked about mine could be a little bit high, and we were going to run some DNA testing to see if maybe it was more genetic.
Yep.
And I was looking, and hopefully I'm looking at the right numbers. I have LDL for when you ran it, April of last year was 137.
Okay.
My primary care ran it, and it says LDL-C was at 160 in July.
Okay. So that
So,
was more recent.
yeah, and I
Okay.
haven't had it run again since because I've been fighting some of that concussion stuff and some allergies, and I just haven't wanted to throw anything out there without getting it all cleared up.
Right.
So based on the graph you showed, am I in line for my age range?
So this graph is total cholesterol. So what's your total cholesterol on there?
In July, it was 224.
Okay. And remind me your age.
46.
46. So you fall right here in the center left. So 226 would be beautiful. So see where the U shape is just is touching,
Yeah.
you know, so excuse me. So you start to pull off that line in the upper 230s, 240. And then check this out too, because I didn't point this out when we were talking about it, but look at so women are the red line, okay? The blue dotted line is men. So for both sexes, you're actually safer to go high than low in terms of how quickly the risk accelerates, right? If you go up to 240, yeah, you're off the line, but you're, you know, even at you're slowly climbing and getting more dangerous going high. If you go too low, if you go 226 to 200, you know, to 180 to 16, now you're really climbing. And as you get to postmenopause, like I said earlier, there's an old study that says postmenopausal women, as they go below 180 and especially close to 150, risk of breast cancer and type 2 diabetes just skyrockets. So, you know, if you're going to err one way, I'd rather err higher than lower, because I don't know where you guys, where the all of our headshots, our little thumbnails are blocking the image or not, but on all of these, except for the 35 to 44, which is the other way, all of these, it's better to go high than low if you have to err one way in the short term. Make sense? So at 226, you know, that you're pretty much, you know, that's great. If the LDL at 130, let's see, did they mention? I don't have it on this one. Yeah, this was looking at total cholesterol versus LDL. But this one here, this newer one, was one of the new targets was anyone over 190. Okay, so at 130, you still had a ways to go before they should tell you to get on a statin because of LDLs.
Gotcha.
Makes sense.
And my primary care has thrown out the word statin to me a couple times, and I just look at him and he goes, "Okay, I'm backing off."
Yeah. Well, good.
So.
And then, okay, say your LDL was 200. Okay. So this is where, you know, you might ask, well, should I get on a statin at that point? Well, we can, and I've done videos on this too, you can parse these out even more specifically. So LDL is called the bad cholesterol, you know, by conventional language. And it's called that because LDL's job is to take cholesterol from the liver out to the periphery and say patch holes in the vasculature or elsewhere. Okay, so if you have a wound, your cholesterol is going to go up because you're trying to plug a hole. If you have surgery and we test your cholesterol a couple days after surgery, it's going to be way higher because you just had a bunch of wounds or trying to patch holes, okay, or patch drywall, whatever metaphor you like. HDL is called the good cholesterol because it pulls cholesterol from the periphery and brings it back to the liver to be metabolized. There's no good or bad. They're both essential. If I have a wound, you know, I want to plug holes. I don't want to bleed out. So that's, you know, LDL is doing its job. That's actually good, right? So if we just treated paper, say we had your cholesterol today and your LDL is 130, and then you have carpal tunnel surgery tomorrow, and then on Friday we run your cholesterol and your LDL is 230, and we give it to a medical student and say, what does this person need? And just by judging the paper, they're going to say, holy cow, she needs a statin drug. It's like, well, no, what about context, right? She just had surgery. Her body's doing the right thing to help her heal from that surgery. We don't want to inhibit that healing process by putting her on a statin and falsely lowering LDLs, right?
Gotcha.
So we want to understand, you know, the context, not just a number on a page. Make sense? So again,
Yeah.
that's the reflection that the LDL and total cholesterol are going to go up when you're inflamed. Well, why is she inflamed? Well, she just had surgery, right? So an inflammatory process is normal when you're trying to heal. If that becomes chronic, then that's another issue. But we want to know the context.
So in other words, another way of inflammation could be, I've got a shoulder thing going on. And so
Mhm.
the pain in my shoulder and the muscles are really just aggravating me.
Mhm.
That could cause a little bit of inflammation in the body.
Yeah,
So that could cause an
potentially.
increase in the cholesterol, correct?
Potentially. Yeah.
Okay.
And then I got sidetracked by myself, but what I was going to say is if we saw your cholesterol, so pretend you didn't have surgery, we didn't have an explanation for the 220 being hot, for it being 220, okay? Well, then before we put you on a statin, we can still do more in-depth testing and parse out the LDLs, because there's different sizes to the LDLs. And there's these things called essentially big fluffy LDLs, and there's small dense LDLs. The small dense are the dangerous ones. The big fluffies are actually shown to be protective. So if you have high LDL count, but most of them are big fluffies, there's no need to go on the statin drug. If you have a high LDL count and it's a bunch of small dense and a bunch of that is oxidized, those are bigger time risk factors.
Right.
So that's a time where we might say, hey, you know, maybe a statin's appropriate here for the short term, in addition to intense dietary and physical activity and lifestyle change, right? With the goal of, we want her LDL at 150 or less at 3 months. Let's retest at 3 months and determine whether or not she should stay on the med. And we want to observe for symptoms through that 3 months. So if you have joint pain or, you know, short-term memory loss or these things that are known side effects, then we might want to dump it sooner, right? And to prevent the fatigue that can be driven by it, here, take CoQ10 at the same time as you're taking the statin, right? So
But
that would be
the LDL test to determine the fluffy or small,
Mhm.
that's not something that most primary cares will run.
No, that's not standard of care.
Yeah, because I asked about it and they looked at me like I was crazy.
Yeah. So then it's, again, standard of care is bad. In my book, I talk about a study that quotes the average American gets 55% of standard of care at their visits. So you're getting half of half-ass care all the time. So yeah, the more in-depth LDL testing is called LDL particles or LDL fractionation or lipid fractionation testing, or NMR testing, depending on if it's LabCorp or Quest. But yeah, you could say, hey, I want to test my particle sizes, and if they look at you weird, then, you know, ask somebody else.
I was just looking to see. They didn't run it for me.
No,
I pushed.
Yeah,
They tried to push back.
and that would, you know, and that it'd probably be out of pocket at that point. Or, you know, if they're not going to run it for you, then really you could push back and say, well, then I'm not going to go on a statin, because what's your basis of putting me on it? You know,
They didn't really like running the CRP for me either.
which is wild, right? That's their favorite inflammatory marker. So if they don't even want to run that, it's like, well, how are you recommending? What are you recommending care on?
They did run it, and then they came back and said, your numbers are too high. We need to discuss how to bring your numbers down.
Mm-hmm. Which medication are we going to put you on?
I ignored it and came to you.
Yeah.